Oh, hey there. Today we're studying joints, rheumatology, so we're finally in room. We had a really good week. I sliced myself with an avocado very bad today. So always remember the flexor digitorum profundus is for your dip joints. Just a little FYI, profundus dip joints, because I had to test those this morning. So we're going through rheumatology part 2 and part 1, so we're going to go through part 2. The first thing we have is Sjogren's. Everyone knows Sjogren's, people can't cry. Dry eyes, dry mouth, dry vagina. Diagnosis is Schirmer's, the filter paper test. So if you have less than 10 teardrops, that is confirmatory. And then greater than 15 is normal. And then we have to remember anti-Rho and anti-LA are the serology. Oh my god, I brought from that. So I remember Sherman, I'll Rho to LA. I don't know how you have associates with that with Sjogren's, but hopefully you remember one of these three and you can remember it's Sjogren's. So treatment is procholinergic. We know anticholinergic drugs dry you out, so procholinergic drugs make you wet. So one of the procholinergic drugs is pilocarpine, and then symptomatic treatment is very important. So artificial tears, vaginal lubrication, anything to take care of your mouth is really important because one of the complications is dental caries, with the other one being APS, antiphospholipid syndrome. What this is, it's a very unique hypercoagulable syndrome where you have clots and miscarriage. So I don't know how to remember that with Sjogren's, but I kind of just think you're so dry that it makes sense to me that you're hypercoagulable. Your blood's like thick, everything's dry, and your mouth more mucousy, so you're gonna throw some clots. The next is scleroderma or crest. Scleroderma is a condition where you do not have moist mucous membranes. Everything's also kind of dry and tight. So it's tight, thickened skin. Crest is a type of scleroderma that is more localized, because when you have crest, you just have these 5 symptoms primarily, whereas diffuse scleroderma, you have a lot of different involvement. So when we have this localized crest, the C is for calcinosis. You have it looks like little nummy things of calcium in your skin. Looks super interesting. Raynaud's, which we know is the fingertips. Esophageal dysfunction. Sclerodactyly, this is hardening. Dactyl means fingers and hands, so hardening on the skin of the hands and fingers. And then telangiectasis, primarily around the face, is spider veins. So treatment, there's no end-all-be-all treatment for scleroderma. It's kind of just treat each individual thing. So for the Raynaud's, calcium channel blockers, renal problems, ACE inhibitors, the reason, and moving on to complications is renal crisis. The reason for this is with the tightening and thickening, it can affect your renal vasculature, so the renal arteries become narrow, and that's why you go into renal failure. Also, pulmonary fibrosis, I think it's a similar thing with the vasculature. So moving down, we have polymyositis. Polymyositis and PMR, polymyalgia rheumatica, can be very confusing, so you have to make sure to very specifically differentiate them in your mind. So polymyositis is inflammation, which leads to muscle weakness. So it's weakness of proximal muscles, such as the shoulders and the quads. So sign and symptoms are going to be you can't reach your cupboard, you can't climb stairs, things like that. So just remember, itis causes your muscles to inflame, and therefore they're very weak. You can't use them very well. So you'd have less than 5 out of 5 muscle strength, probably like 2 or 3. Itis, myositis, muscle inflammation. Of course, we're going to have high creatine kinase. Treatment, high-dose steroids. Moving on to dermatomyositis. This is very similar to polymyositis, plus one thing. You have a heliotrope rash, which is a purplish rash around the eyes. It looked like someone punched you. You can remember people punch dermatologists because they're not real doctors. And then the one thing to note for this class, there's a very high rate of malignancy with dermatomyositis. So moving down to PMR. PMR is kind of confusing, but it's associated with GCA, giant cell arteritis, which is a vasculitis, and it's pain, stiffness, in the hip and shoulder girdle. So really remember pain and stiffness versus weakness. So I remember that's pain and stiffness because myalgia means pain, and then it's of the girdles, like the joints, so rheumatology is joints. So just remember this doesn't just affect the muscles, it's pain and stiffness of the joints, the hip and shoulder girdles. So with that, we're going to see ESRCRP, pain greater than a month, and then another diagnostic criteria is rapid response to prednisone, less than 20 milligrams. So with that, treatment is going to be prednisone. So moving on.
Alright, everyone, so we're going over rheumatology 1, or part 1. So we're going to go ahead and start with rheumatoid arthritis. So remember this, if you have RA, do meth. I'll kind of explain why in a moment. So signs and symptoms, you're going to have symmetric arthritis, but it avoids the DIP joint. So that's going to be really important to differentiate from other arthritis. So rumor is you don't dip. So rheumatoid, don't dip. You don't involve the DIP joints. Diagnosis is going to be ACR, you have to have 6 out of 10 or greater. Treatment's going to be NSAIDs, DMARD, so methotrexate, which is where we come back to the if you have RA, do meth, because that's going to be your treatment of choice, is that methotrexate. You can also use biologics, so TNF or IL-1, which is like a chemo drug apparently. You also want to ensure that you vaccinate your patients because they are immunocompromised with this. So, one thing I did forget to mention with the signs and symptoms is that they're going to have morning stiffness that's greater than 30 minutes. So now we're going to go ahead and move down to JIA, or juvenile idiopathic arthritis. And there are 3 types that are going to go along with this. So you have, is it POSI?
Uh-huh.
And then you have oligo. So those are kind of the same thing, just 2 different ways to call it. And with this, you're going to have less than 5 joints involved. Then you have polyarticular, which is 5 or more joint involvement. And then you have systemic, which means that all of the joints are involved. And this is also referred to as stills, so make sure you know that. As far as treatment, they all are going to be NSAIDs. But when you come down to the other 2, you have 5 or more, all of the joints included. You're also going to include steroids in that treatment as well. So now we'll move down to ankylosing spondylitis, and this is really important because Shannon came up with a great mnemonic to remember this. We want to go and give her some credit, so good job, Shannon. So signs and symptoms, you want to remember B spontaneous. So B27 is the gene that's associated to this, and you want to know that. So you just write a 27 above the B, and then below the B, you're going to write bamboo. And the reason why is because you're going to see a bamboo spine on X-ray. It's going to help you differentiate that. This is the hardening of the spine and the SI joint. As far as treatment, just NSAIDs, so super easy treatment for, hardening of the spine. We then move down to reactive arthritis. So this is an autoimmune condition that occurs 1 to 4 weeks after gastroenteritis. So it's really important to get that history from your patient. A really big thing with diagnosis and kind of taking care of your patient is you really want to make sure that you're testing for HIV specifically and also chlamydia. And then as far as treatment, you do NSAIDs plus or minus a steroid, just kind of depending on where your patient is. We then have SLE or lupus. This is going to be the butterfly rash, also known as a malar rash, that is sparing of the nasolabial area. So here's our individual, and they have just like those butterfly wings right here. So one thing you want to remember is SOAP, Brain MD. We're not going to go through all of them today, but you can reference back to your slides, and they're in there. And the criteria is to have 4 out of 10 of
11.
those. 4 out of 11 of those. Sorry. A few things we kind of used to help remember this is feeling loopy when you get soap in the brain. And then as far as screening, you're going to have to do an ANA, and they're going to do some confirmatory labs as well. So you're going to have the anti-Smith and the anti-TNA. As far as treatment, first line is going to be hydroxychloroquine. That's first line, and then you can also use steroids for any flares that occur with these individuals. So again, today we went over rheumatology, so thanks for tuning in.